Hi, everyone. I'm Christopher Weiner. I'm a psychiatric mental health nurse practitioner, suicide prevention strategist, and a nurse who has lived through some of the hardest parts of this work myself and in my family. Before we get into that content, though, I want to pause on this image. So, this is Dr. Lorna Breen, an emergency physician who died by suicide early in the pandemic. And you can see this portrait here was part of an exhibit called The Disposables. It's made from donated medical materials, the same kinds of gloves, gowns, and packaging we throw away every shift. And the point of the exhibit is simple, and it's brutal. A lot in healthcare is designed to be disposable, but our people are not. Today is not a generic wellness talk. I want to connect three things, and that's our lived experience as nurses, what the science actually says about workplace well-being, and the concrete levers that we can pull in our schools, our departments, and even our organizations. So my hope is that you leave here feeling seen with a clearer sense of what real well-being looks like in nursing, and with a few specific actions that you can take, whatever your role is, student, bedside nurse, faculty, leader. So I'll start with a bit of my own story, and then we'll zoom out to the research, and we'll land on what actually works at the individual, department, and organization level. So when we talk about well-being, it's easy to jump straight into the individual interventions, kind of like sleep more, meditate, hydrate. And those things matter, but they're only one piece. And I like to think about impact in three levels. First, the organizational level. And those are policies, staffing models, benefits, employee assistance program, how mental health and errors are handled. Those decisions set the conditions we all work in. Second, the local or department level. And this is your unit culture, your manager, how huddles, schedules, and peer support actually play out like day to day. Third is the individual level, or our own skills, habits, and supports that help us cope with stress and stay grounded. For the rest of our time, I'm going to keep moving back and forth across all these three levels, because real nurse well-being only happens when all three are aligned, not when we put everything on the individual nurse. So we talk about nurse well-being like it's a nice to have, or something you do once everything else is done. But the reality is this, is that burnout and moral injury are prevalent and high across every setting. We are losing nurses from the workforce, and people are afraid to say that they're struggling because they worry about being judged, reported, or seen as unsafe. We're not just talking about stress here. We're talking about increased risk of depression, anxiety, substance use, and suicide among health workers. So this is not separate from patient safety. Team well-being is a patient safety issue. It's also a workforce issue and a human issue. I want to start with why this topic is not theoretical for me. My story with suicide began very early. When I was 5, my grandfather died by suicide. At that age, I didn't understand what had happened. But I remember the confusion and learning that a person could actually end their life. And as I grew up, that unspoken pain didn't disappear. I carried depression, trauma, and what I now know is ADHD into adolescence and adulthood. I had suicide attempts, I took risks, and made choices that only made sense if you believe your life doesn't matter very much. At one point, I held a very strong belief that death would be better than living. And that was just because the emotional pain felt unbearable and permanent. I wasn't being dramatic. It felt like a logical conclusion to me at that time. In one therapy session, a clinician looked at me and said very calmly, "Chris, how do you know that death is better than living?" No one had ever challenged that belief, that belief I had out loud before. And that question landed at exactly the right moment. It forced me to pause. It created just enough space for curiosity instead of certainty. And I remember thinking, man, if I can't actually know that death is better, then I have to at least consider the possibility that staying might be worth it. And that opened the door to a different question. And it was, okay, if I'm supposed to be here, what am I supposed to do with this history, this pain, this experience? So that moment didn't magically fix everything, but it nudged me onto a path of healing instead of giving up. Over time, the path led me to a deeper in nursing, into ICU work, into seeing how much our systems, truly do ask of people, and how little support they provide. Later, a childhood friend of mine, we reconnected, like time never passed, and he died by suicide back in August of 18. And also, I stood at my daughter's bedside after her attempt, and everything kind of converged. My grandfather's death, my own attempts, my friend's suicide, and now my daughter's pain, and my experience as a nurse watching colleagues burn out. In that moment, I made two commitments. First, that she, my daughter, would never walk through this alone. Second, that if we were going to survive this, I would use our story and my training to help change how we respond to suicide risk and emotional suffering, and especially in healthcare. And that is why I became a psychiatric mental health nurse practitioner, and why I focus so much on health worker well-being and suicide awareness, intervention, and postvention. And I'm a suicide attempt survivor, a suicide loss survivor, and the parent of a suicide attempt survivor. I've seen how policies, culture, and stigma can either push people closer to the edge or pull them back. I share this for two reasons. And one, if you carry your own history with suicide, you are not the only one in this room. And two, the rest of this session is not about abstract wellness programs. It's about what it actually takes for nurses, students, faculty, and leaders to stay alive and well in the work. With that context, let's zoom out to what the research tells us about nurse suicide and workplace well-being, and then we'll come back to what we can actually do in our systems and in ourselves. So we'll head to the next slide here, which is, I want to ground this in data, not just in my story. This graphic comes from work by Judy Davidson and colleagues looking at job-related problems prior to nurse suicide. They identified a pattern that many of us recognize, and that's that chronic struggles like mental health challenges, substance use, chronic pain, and overwhelming stress slowly funnel people into a crisis. And as you move down the funnel, you can see things like peri-job loss, feeling trapped, no way out, tipping points, and then suicide. And these are not people who suddenly snapped. They are nurses who were struggling for a long time in environments where it often wasn't safe to say, I'm not okay. Some of the most common themes in this research are loss of purpose, fear of job loss, substance use, worsening mental health, especially after bereavement, poor general health and chronic pain, and even repeating a family member's suicide. So when you hear that, you can almost picture real colleagues, right? I want you to notice this is not just about an individual's diagnosis, though. It's about the interaction between a person and a system that often responds with punishment, silence, or avoidance instead of support. So what does this actually mean for nurse leaders? There's a new study that was done called Job-Related Problems Among 2021 Nurse Suicides, and it really identifies that leaders can't stay on the sidelines anymore. They need to be proactive in reaching out when someone is in crisis. Waiting for a nurse to come to you is often way too long. Second, suicide prevention skills can't be optional. Leaders and frankly everybody should be required to attend training that covers how to recognize warning signs and how to have that direct compassionate conversation about suicide, and ask the question, are you thinking about killing yourself? And how to connect people to real resources. Connecting somebody to resources can literally save a life. And third, we have to rethink our reflexes about removing people from their jobs. The research shows that they're really fighting for protected time, for healing and recovery, because then that approach really treats mental health like any other condition that requires treatment and recovery. And fourth, they call for spaces to grieve and to process trauma outside of like debriefs and root cause analysis. Spaces that focus on how it felt and the emotional toll. And nurses report having intentional space and time to share with those peers really reduces isolation, builds connection, and also strengthens resilience. If we only do root cause analysis and never address the human side, nurses learn to suppress their emotions as a survival strategy. And over time, that emotional numbing leads to burnout, compassion fatigue, and even suicide. So creating ongoing safe spaces and emotional processing is really a safety intervention, not a luxury. So we've all heard some version of fill your cup, right? So, oh my gosh, it's been beat into our heads. Take a yoga class, drink more water, download another mindfulness app. But this slide is the reality I hear from nurses all over the place. And the cups are empty not because we're weak or not resilient enough, but because the system keeps tipping them over, or the cups are just broke. And chronic short staffing, moral distress, bullying, fear of making a mistake, fear of losing your job if you speak up or seek help. So from here on, I don't want to talk about wellness as an individual project. I want to talk about the science behind why nurses feel this way and what actually works at the organizational, departmental, and individual levels to change it. So that's where we're going to go next. So, given all that, we have to be really clear about what nurse well-being is not. And it is not yoga in the conference room after a 12-hour shift, especially when you can't get a break or even pee during that 12-hour shift. It is not pizza parties or coloring sheets while staffing ratios remain unsafe, and it is not one more resilience training stacked on top of mandatory education. Those things might be nice add-ons, but if that's all we do, we send the message that the problem is nurses not coping well enough, or rather than, serious problems in how work is designed and how people are treated. And I think at its core, I like to focus on the behaviors because well-being can become a buzzword if we use it without really identifying those behaviors. And it's really psychological safety. Do you have the comfort to speak up or to share your story without fear of consequences? Is things fair and is there trust in your department or with your leader? Is the workload manageable and predictable? Does your voice actually have shape the outcome and does it have an impact? And it's about real support when you're struggling, not just calling EAP if you're in a crisis, but a culture where you can tell a colleague or a leader that you're not okay and be met with compassion, clear options, and no fear that your career is over. When all these things are present, well-being has a foundation. Without them, no amount of wellness programming can fix the core problem. So, research across occupational health, organizational psychology, and nursing science is remarkably consistent. And it shows that burnout and well-being are driven far more by job demands and resources, or a lack of them, leadership, and culture, than they are about individual coping skills, things like workload, control over your schedule, recognition, community fairness, and alignment of values. Those all predict whether people thrive or burn out. We also know that psychological safety, the belief that you can speak up, make a mistake, or say I'm struggling without being punished or humiliated, that's strongly linked to team performance, learning, and patient safety. So when we talk about nurse well-being, we're talking about how work is structured and how people are led, not just about how tough individual nurses are. You might have seen this slide before too, or this phrase, I should say, which is culture eats strategy for breakfast. And I like to show it this way, is that culture is the big yellow Pac-Man and strategy is the little ghost. And you can have the best written strategy. You can have beautiful posters, right? And a well-worded well-being plan. But if the day-to-day culture on the unit is fear-based, shaming, or unsafe, culture will win every time. If the unwritten rules say don't speak up, don't call in sick, or if you admit you're struggling, you'll be seen as weak, then that culture will swallow any well-being initiative whole. When the culture is unwell, nurses feel it in their bodies. You might notice dread in the parking lot before a shift starts. You might see high turnover, cliques, or people eating their young. You might hear phrases like, oh, that's just how it is here when someone points out a problem. What I want you to notice is that these are not personality traits. These are symptoms of an unwell culture. And if we only focus on individual nurses and coping skills without changing the culture, we're treating the fever without addressing the infection. And this piece, I think, is especially important for students and faculty, is that students don't just learn skills, right? They're learning culture. They learn when and if it's safe to ask a question, or learning that taking a break is allowed or seen as weakness. They learn how nurses talk about their patients and about one another and about themselves. Faculty and preceptors are constantly teaching culture without even realizing it. So a shaming comment, an eye roll, or even a sarcastic remark can live inside a student for years. So part of prioritizing nurse well-being is being intentional about the culture we are modeling, especially for the next generation. So now let's bring this to the department level or the local level, because that's where people feel culture most strongly. A great leader changes everything, not because they fix every problem, but because ultimately they change how the unit feels. On a healthy unit, staff have predictability. They know what to expect, even when things are busy. Leaders are present, often visible and calm, not just in their offices. It's okay to speak up and struggle, and you can say, like, hey, I'm not okay right now. It's also your voice. Again, you have a voice that actually matters, and is taken into consideration and used for change. And ultimately, fairness matters, and that expectations are consistent, and that there's no favoritism. And staff, like I said, that voice, I tap back to that. I think governance, professional governance, shared governance are all super important things. And not just governance that's done on paper, right? But where nurses can see their fingerprints on the solutions. If you ever worked for a leader like that, who exemplifies a lot of those things, then you know how protective it feels, even when the larger system is still messy. And I think you all can take a second and even think about some of those leaders that had a dramatic impact on you, and how they made you feel safer at work. So at the organizational level, there are some clear things that make a difference. And that's, first off, is that confidential access to healthcare that does not threaten somebody's job or license, or even if people believe that getting help will be punished. They'll often wait until crisis or never seek treatment at all. And then peer support and structured postvention after distressing events or losses. When there's a tragic outcome, a colleague death, or an adverse event, staff need time, structure, and support to process it. And a lot of times what we do after postvention is prevention. Third, adjust culture and learning focus response to errors. You can see a lot of similarities across these things, is that it doesn't mean there aren't any boundaries. It means that we focus on what and why something happened, not just who is to blame. And fourth, I think safe reporting, and especially when it comes to reporting for workload or workplace violence or bullying, safety concerns, and most importantly, that visible follow through, because we all know how it feels to report something and nothing happens. And, finally, the well-being needs to be on dashboards, right alongside quality and patient safety. If it's not measured and reviewed, it rarely gets resourced. So I want to be clear, is that individual skills absolutely matter. So what you're going to learn today, a lot of these things, they're not just garbage. They're just not the whole answer. And so brief grounding or reset practices woven into your day can help bring your nervous system out of fight or flight and back online. And that might be 30 seconds of box breathing during hand hygiene, or a short grounding ritual before walking into the department. Being able to name what you feel. I'm overwhelmed, I'm angry, I'm numb. Instead of automatically numbing with things like substances or scrolling or overwork, it gives you a choice point. And self-compassion instead of self-blame allows you to say, of course this is hard, I'm human, instead of like, what's wrong with me? Why can't I handle this? Boundaries around time and availability matter, and it's okay to say no to extra shifts when you're depleted. And reaching out earlier, not later, when you're struggling is an act of professionalism, not weakness. But I'll say this again. These skills support you. They do not replace the need for systemic change. You should never have to box breathe your way or yoga your way out of abuse or unsafe conditions. So what does this all mean? For nurses, your experiences are data, not weakness. When you feel morally injured, burned out, or unsafe, that's useful information about the system and to yourself. Your voice matters. For students, pay attention to culture. If you feel like you're the problem because you can't tolerate something, ask whether what you're seeing is actually healthy. You are not supposed to be okay with everything. And for faculty, you're shaping culture, not just teaching content. The way you respond to mistakes, questions, and vulnerability will echo in your students' practice for years. And for leaders, you are the strongest protective factor on your department and in your unit. You do not have to be perfect, but your presence, your fairness, and your willingness to listen and act are powerful forms of suicide prevention. And, if you would like to dig a little bit deeper, what I created was something called an anticipatory stress skill guide, based off of nurses with lived experience, who said this is one thing that we would love to have skills around, and also a lived experience advocacy toolkit. So if you scan that QR code, you'll get practical tools for safely and meaningfully bringing lived experience into your workplace or school. Also some conversation guides, safety considerations, and ideas for advocacy that don't require you to disclose anything you're not ready to share if you don't want to. So by downloading it, you agree to receive some occasional updates and resources from my company, Empowered Psychiatric Solutions, and you can unsubscribe at any time if it's not helpful. My goal is to keep equipping you, not to spam you, believe me. I don't send out a lot, so don't worry about that. But I just want to say thank you so much for watching. Thank you so much for your time, and I really appreciate you. And let's make well-being an organizational and health system priority for all health workers. Thanks. Thanks for checking out Empowered Stories Podcast. Our next episode will be coming out shortly. Don't forget to subscribe to Empowered Psychiatric Solutions YouTube channel, where you can be the first to watch all this exclusive content. Also, you can check us out on Spotify at Empowered Stories Podcast. Thanks so much for your support.